So without further ado, I am so excited to introduce our keynote speaker, Dr. Haffizulla. Dr. Farzanna Haffizulla is the chair of the Department of Internal Medicine at Nova Southeastern University, Dr. Kiran C Patel College of Osteopathic Medicine. After having served as the Assistant Dean for Community and Global Health and a founding team member at NSU's College of Allopathic Medicine. She's a board certified practicing internal medicine physician and founded and runs a hybrid concierge internal medicine private practice in Davie, Florida. Dr. Haffizulla completed her undergraduate degree in molecular biology and microbiology at the University of Central Florida in Orlando, graduating summa cum laude with university honors. She earned her Doctor of Medicine degree from the University of Miami Miller School of Medicine and completed her residency training at Cleveland Clinic, Florida and Cleveland Clinic Foundation in Ohio. Dr. Haffizulla is focused on promoting health, wellness, and disease prevention, both locally and globally, and has been invited as a thought leader to participate in related sessions at the National Institute of Health and the Office of Women's Health. Dr. Haffizulla is also a host, anchor, and clinical editor for the nationwide health program, Mission Critical Health. And I will tell you, her bio goes on even longer. She's done so much, and we're so lucky to have her. I encourage all of you in our program journal on the website for this conference to read the rest of Dr. Haffizulla's bio and all of our presenters today. And without further ado, I'd like to introduce you to Dr. Farzanna Haffizulla. We're so excited to have her.
Thank you so very much for that very kind, warm introduction. It is truly my honor and my privilege to be here today and to become a part of a movement where we're going to be converting our conversations into action. This is, yes, hope and research today, but this is a call to action. So today I'm going to go through a snapshot of some of the data that outlines some of the serious cancer care disparities that we're experiencing here in the US. And then I'm going to take you on a journey about different actionable strategies. I am very grateful to my team at NSU. I see that most of my leadership are here. Many of the community leaders that I also work with are also here. I know Lorraine is chairing this particular conference, and I'm excited about that. But our institution, Nova Southeastern University, it's a majority minority institution. It's also a designated Hispanic serving institution. And as the moment I came in, actually I joined in 2017, President Hanberry afforded me a quality of life grant that allowed me to continue with all the health equity work that I'm engaging with my team. So this is now a way for me to ensure that we are putting more muscle behind our work together and that we synergize our efforts. So with that, I'm going to share with you a little bit of the economic impact that will be felt if we were to eliminate cancer care disparities in racial and ethnic minorities. So there was a quick review done, an economic analysis done back in 2003 and 2006 that showed that if we eliminated health disparities for all racial and ethnic minorities, we would actually reduce direct medical costs by about $230 billion. And indirect costs associated with illness and premature death would be reduced by more than $1 trillion. So that just gives you a snapshot of a moment in time. Today, in my objectives, I'm going to outline discussing and defining what cancer care disparities are and providing supportive data. And then I will show you a snapshot from all different areas affecting racial and ethnic minorities to show the complexity of health disparities and how those relate to the cancer control continuum. And then finally, we're going to outline strategies and actionable plans. And this will not only promote equity, but it's a conversation starter. So at the end of the presentation, I hope to hear from you. Maybe some of the plans that you have in place that are working, some of the actionable strategies that might be in the very beginning stages where you might need other partners to get engaged and involved. Everyone here is at the table. So this is a wonderful opportunity for us to move forward. So according to the National Institutes of Health, designated US health disparity populations are right here on the left-hand side of my slide. So African-American population or the Black population, Hispanic and the Latino community, American Indians and Alaska Natives, Asian Americans, Native Hawaiians, and other Pacific Islanders, any socioeconomically disadvantaged populations, those who are underserved in rural populations, and sexual and gender minorities. Now, there are race and ethnic categories, and these were revisions as designated by the Office of Management and Budget Directive 15. And here we have the categories. Now, I'll tell you, I'm originally from the Caribbean, and I'm an other. I'm never fitting into any one of these categories. So while it is an attempt to ensure that we unify and categorize the diversity of our country, it only really touches the surface of the true level of diversity and genetic ancestry associated with each individual person. I absolutely support, and I'm a very big believer in personalized medicine and ensuring that we have individualized care and understanding the unique variables that come with each patient and each person that we are so privileged to treat. So these racial categories and ethnicity categories are more socially constructed. And as I mentioned, it is done this way so that you can have some unification within official registries and health systems and in the decennial census. But again, that broad diversity that exists within each of these categories, many studies for the past 15 years or more usually report some subpopulation analyses. So we're looking at geography, country of origin, socioeconomic status, and genetic ancestry. And if you look a little further, you'll note that a lot of the data that's been collected on race and ethnicity really relies on individuals self-reporting this information. So while those categories might be influenced by sociopolitical constructs, they really don't fully reflect the individual's genetic ancestry. And I'm going to really hone in on that point because there are genetic components that we'll talk about a little later that really put you on a trajectory towards manifesting specific cancers. And it's important for us to know that. So let's talk a little bit about cancer disparities and where they are and who's affected. So according to the National Cancer Institute, they've described cancer disparities or disparities in general as adverse differences in cancer measures. So we're looking at the number of new cases, we're looking at the number of deaths, cancer-related health complications, survivorship, and quality of life after cancer treatment, and screening rates, the stage of diagnosis that exists among these populations. So racial and ethnic minority groups that I just outlined, that is where the focus of this talk is today. But also individuals who lack health coverage or have limited health coverage, those who are refugees or asylum seekers, adolescents and young adults, residents living in geographic locations like rural areas, and those of different ancestry, or those who are members of the immigrant population, those with disability, our elderly population, our LGBTQ community, and those of low socioeconomic status. That just gives you a snapshot of who is deeply affected. I'm going to give you a little bit more of a data snapshot, and this was teased out by the AACR's progress report on cancer disparities. This was their inaugural report, because we know that the pandemic is really shining a light on the disparities that have been pervasive, long-standing, and deeply embedded in our society for a long time. So if we look at some of these statistics here, African-American men have a prostate cancer death rate that is more than twice that of white men. Our Hispanic children are 20% more likely to develop leukemia than non-Hispanic white children. Asian and Pacific Islander communities are twice as likely to die from stomach cancer as compared to white adults. And the American Indian and Alaska Native adult populations are twice as likely to develop liver and bile duct cancer as white adults. Adolescents and young adults with head and neck cancer who have no insurance, they are 51% more likely to die from their disease than those who have private insurance. And then men living in the poorest US counties have a colorectal cancer death rate that is 35% higher than men living in more affluent US counties. And then finally, 70% or more of the bisexual women here in this country are more likely to be diagnosed with cancer than heterosexual women. This is a snapshot showing you the overall cancer death rate differences. And just by looking at this, you see from the year 2000 to 2017, which is a time period captured in this graph, there is a narrowing of the number of death rates, of deaths essentially among each of the race and ethnicity categories. And while that number is declining, it is glaring that our African American community still remain extraordinarily and deeply affected disproportionately by cancer deaths. In fact, it's more than 40 years, that's 4 decades, that African Americans have had a higher overall cancer death rate than any other racial and ethnic group here in the US. If you really want to look at numbers, it's an estimated over 202,000 African Americans were diagnosed with cancer, and over 75,000 died from this disease back in 2019. So that just gives you a little bit of an idea of the depth of the disparities, and that is just only the tip of the iceberg. What we are seeing is what's reported in the data, but there are elements in different populations that are not captured by the data that we're seeing. In this particular slide, I'm showing you the incidence and death rate, the difference in incidence and death rate, or the disparities rather, between African Americans and whites for selected cancer types. Now, on the right-hand side of each of these blocks, you see something called the rate ratio. If that rate ratio is greater than 1, that is certainly a disparity. So if we look over to the smaller box that talks about incidence rates, almost every single cancer, there is a higher incidence rate in African Americans as compared to the white population, all except in the breast cancer realm. If we look at death rates, prostate cancer in males, African American males, far outweighs any prostate cancer deaths in the white population. And going down the list, you'll see that almost all cancer death rates, again, are higher in our African American population, all except for kidney and renal pelvis cancer. Let's look at the disparities in incidence and death rate now between Hispanics and whites in selected cancer types. It's important to note, though, before diving into this data a little bit, that our Hispanic population in the continental US and Hawaii is highly diverse genetically and ancestral genetic DNA. So the differences have been employed by country and region of origin, and the different degrees of ancestry range from some indigenous American, European, and African ancestry. And these differences between US-born and foreign-born Hispanics also play a very big role in the manifestation of specific cancers. I'll tell you then one very powerful example of the difference in cancer burden between Hispanics in the continental US and Hawaii and those in Puerto Rico is that prostate cancer incidence rate among Hispanic men in Puerto Rico is 60% higher compared with Hispanic men in the continental US and Hawaii. You see liver cancer right here at the top of this list, right? Now, liver cancer is one of the types of cancers with the most striking disparities in incidence and death rates between Hispanics and whites here in the US and Hawaii. And several studies have actually shown that among Hispanic men in the continental United States and Hawaii, those born in the United States have a liver cancer incidence that's nearly double those born outside of the United States. Now, for Hispanic women, US born and foreign born, the rates are actually comparable. So in addition to Puerto Rican Hispanic men living on the US mainland, they have a higher liver cancer incidence rate than those living on the island of Puerto Rico. These disparities are in large part attributable to many higher rates of exposures to risk factors for liver cancer. So hepatitis B infection, hepatitis C infection, obesity, alcohol consumption, smoking, diabetes, just to name a few. If you look at stomach cancer on this list, stomach cancer is another type of very dramatic disparities in incidence and death rates between Hispanics and whites in the continental US and Hawaii. Now, Hispanic women experience greater disparities in stomach cancer incidence and death rates than Hispanic men. Now, this chart actually just aggregates both sexes unless it's specified in here. Now, one study actually here in Florida showed that there was a great difference in stomach cancer death rates between Hispanics living in Florida, but who are from Central America and South America versus Cuba. And again, this is related to specific risk factors. We're looking at infection with Helicobacter pylori or H. pylori and obesity. If you look at cervical cancer on this list, the rate of cervical cancer screening is lower among Hispanic women compared with white women. The new data, though, shows that if we look to the future, we find that more Hispanic adolescents are getting HPV vaccines, so that may lower the cervical cancer rates. Now let me switch to talk about the American Indian and Alaska Native population and the Asian Pacific Islanders and our white population comparison, looking again at incidence and death rate of cancer. Now, disparities in liver cancer incidence and death rates between American Indians, Alaska Natives, and whites are particularly striking, and in large part due to the high exposure of those risk factors that I mentioned for liver cancer. So hepatitis B infection, hepatitis C infection, chronic liver disease, obesity, alcohol consumption, smoking, and diabetes. Now, thinking about these risk factors, a lot of them are preventable or modifiable, but how well are we taking care of our community? How much culturally appropriate health education is out there? How many community health workers do we have engaged in our health system? How well are we helping our patients navigate our very complex health system? Many people are left out. They don't know how to navigate those roads, and not knowing how to navigate those roads alone is a death sentence for many. So it is our job, our role, to make sure that we take a comprehensive approach in treating all patients. So these health disparities exist for many reasons, as you see here on the right-hand side. Now, research have identified these many factors, and again, I'm highlighting data from the Progress Report on Cancer Disparities. So among these very complex and interrelated factors, we're looking at social factors, such as your education and income. Clinical factors, as was mentioned earlier, your access to healthcare. Behavioral factors like tobacco use, obesity, and physical inactivity. We have cultural factors that play a very big role, like cultural health beliefs. Psychological factors like stress and mental health. And I will say that most of the social injustice that's been going on in this country has played a very big role in creating high levels of stress that can cause now worse outcomes in cancer. Environmental factors such as housing and transportation, and then biological and genetic factors. I'm going to tease out a couple of these areas just a little bit to dive a little bit deeper. If we look at some of the statistics related to potentially modifiable risk factors, we know that about 4 out of 10 cancer cases and almost half of all cancer-related deaths are actually caused by these potentially modifiable risk factors. Modifiable risk factors like tobacco use, poor diet, or lack of access to healthy foods, alcohol intake, physical inactivity, infection, obesity, infection with cancer-causing pathogens in particular, and exposure to UV light. Other behavioral factors are also very much influenced by clinical, cultural, and social factors. So the way we are approaching cancer screening recommendations needs to be revised. We cannot have a one-size-fits-all approach. Understanding your community, speaking in a language that is going to be embraced, making sure that the clinical care team is diverse and representative of the community that we treat is essential. If we're looking a little bit further, as I mentioned, psychological factors, social injustice and racism has played a very big role in increasing psychological stress, and stress responses, again, as I mentioned, are overall very much correlated with a higher mortality and poor overall cancer survival. Depression and anxiety-related symptoms as well is associated with a 97% increased risk of cancer mortality in people with a history of cancer. Women, for example, who have reported a greater number of major traumatic or stressful life events or having greater feelings of discrimination, they were about 85 and then 17% more likely to not be up to date with their cervical cancer screening. With regard to cancer type-specific outcomes, we know that stress itself has been linked to poor outcomes in breast, lung, head and neck cancer, hepatobiliary, lymphoid, and hematopoietic cancers. Women with breast cancer, actually, on the flip side, who don't report traumatic or stressful life events, they have been found to have a disease-free interval that's twice as long as those who experience one or more stressful or traumatic life events. Even marital status plays a role. So cancer patients whose marital status, if they're separated at the time of diagnosis, they have a 10-year relative survival rate that is about 36% lower than that for those who are married at the time of diagnosis. Let's dive a little deeper into the biological and genetic factors. So the Human Genome Project was completed. There's significant, of course, interest in understanding the association between biological and genetic factors and how that translates to cancer health disparities. However, the genetic studies that include minority populations are still significantly underrepresented compared with studies that include individuals of European descent. We have to do better. We have to ensure that our recruitment, and when I attended that special session with the NIH Office of Minority Health on recruiting more minorities into research trials, we talked about many different ways, but the way that the recruiting is being done does not really take into account social determinants of health. It did not take into account the priorities set by different groups. So we really have to reimagine the way clinical trials are to be done. We know that numerous studies on the biological end, they've uncovered ancestry-related differences in prostate cancer and breast cancers from African Americans and whites, definitely at the genetic level. Let's talk a little bit more about the social determinants of health and social determinants of cancer, as I like to put it. This is a wonderful diagram from Hyatt et al., and this really gives a good diagrammatic description of the complex interplay of factors that are really going to make a difference in cancer outcomes, or can make a difference in preventing cancer in the first place. So the NCI, the National Cancer Institute, defines social determinants as the conditions in which people are born, they grow, they live, they work, they play, and age, and that includes the health system. Now, this can be considered at the level of the individual, groups, communities, or society. And this basically provides context within which cancer itself can be prevented, detected, and treated. Structural and systemic racism is a driver of adverse differences in social determinants of health experienced by racial and ethnic minorities. Inequalities, for example, in socioeconomic status at the level of individuals, neighborhoods, and regions are among the most important social factors contributing to cancer health disparities here in the United States. One recent study actually estimated that eliminating socioeconomic disparities could prevent 34% of cancer deaths among US adults between 25 and 74. The increased realization of the importance of social determinants of health prompted our Department of Health and Human Services to actually include social and physical environment as one of the 4 overarching goals of the first the Healthy People 2020, now it's going to be Healthy People 2030 initiative. There are also efforts to standardize tools to obtain information from patients about social determinants of health and to develop standardized measures of contextual factors that really capture the social, cultural, and physical environment. In the research that I'm doing with my team, where we are focused on the Caribbean community here in South Florida, we've adopted some validated surveys that capture the complexity related to social determinants of health, so we truly understand the background, the priorities, the main issues associated with each of our patients that we're treating. And we're utilizing this data to create culturally relevant health information that will make an impact in reducing diabetes, in reducing obesity, in reducing risk factors for developing cancer and many other comorbid illnesses. Information on the social determinants of health, as you know, has the potential to help clinicians provide better care for their patients, support their patients in a better way, and gives information on those contextual factors. And the patient information that can be used by cancer health disparities researchers who gain a more integrated and comprehensive understanding of all the interrelationship of these various factors. And that is how we really will be able to achieve health equity, is getting that granular and getting that detail that is so important. If you look at healthcare, even after the implementation of the Affordable Care Act back in 2010, many Americans still remain uninsured, with Hispanics and Latinos being the most affected group. Few US systems also offer integrated care. Most patients now have to coordinate and integrate their care on their own. They have to find their own specialists and know what the next best step is. Racial and ethnic minorities are known to be disproportionately affected by this approach. And this also is due to cultural and language barriers. and a historic mistrust in the healthcare system. Going back to socioeconomic status, I'm still on the social determinants of health. Self-reported race or ethnicity correlates with socioeconomic status, and in turn, low socioeconomic status has been associated with poor access to high-quality care, lower screening rates, delays in treatment after diagnosis, and lower treatment adherence. And cancer health disparities between racial and ethnic minorities and non-Hispanic whites can be explained partly by these associations. Financial distress, we know, prevents adequate care, starting prior to diagnosis through imaging and then through pathological confirmation. Immunotherapy that has been at the forefront of cancer care without being able to afford treatments that are related to the newest advances in cancer care, it really does not then make a difference in the lives of our patients. So it behooves us to make sure that we make not just sure that there's access to care, but there is affordable options of care. Among immigrant populations who have not long been in the US, limited English proficiency is another additional barrier to accessing healthcare services. Some other risk factors, as I mentioned, there are environmental exposures that are prevalent here in the US that might lead to an increased risk of mortality for certain cancers. The surveillance, epidemiology, and results of the SEER program data. There is a lot of country of origin data missing from this, so we have to interpret this data with caution. Looking at the genetics, and this is on the biologic end of things. If we include genetic ancestry in studies and focus on the molecular biology of cancer and admixed population, that is essential to prevent confounding of data. Okay? We really will get a true understanding of what some of the drivers are that cause specific cancers to be more predominant in specific racial and ethnic groups. We will get more insights, for example, into triple negative breast cancer and aggressive prostate cancer that disproportionately affects our African American and Black community. Race and ethnicity, as you know, and socioeconomic status, as I mentioned, are highly correlated. You cannot study them separately. They must be studied together. And if you take an intersectional approach that focuses on this complex interaction of social determinants with other factors that are experienced simultaneously, then you provide an opportunity to disentangle their joint effect on the observed disparities. GWAS, or genome-wide association studies. We've studied several loci associated with increased risk of breast cancer, for example, but these variants have been primarily described in European populations, and other populations remain underrepresented. You cannot extrapolate data from a population that does not relate to those experiencing the disparities. Again, it is all the more important for us to ensure that we have diverse patients included in our research. This is from the American Medical Association that dives a little deeper into the social determinants of health. There are 6 common domains here. We have economic stability, and that is related anywhere from employment to debt, medical bills and support. We have our neighborhood and physical built environment, where we have anywhere from housing and transportation, safety, playgrounds, parks, and walkability. We have education listed here, where we're talking about literacy, health literacy, language, or the ability to understand the information that's coming to you. Vocational training, higher education. Food, access to healthy options, and then hunger that still exists here in this country. On the community and social context side, social integration. We just talked about social isolation that has been a persistent issue throughout the pandemic. Community engagement, which is very important, but also we need to make sure that we synergize our work and never remain siloed. Discrimination and support system, and then the healthcare system, not just coverage, provider availability, diversity of that healthcare workforce, and provider linguistic and cultural competence and quality of care, and making sure that we afford quality of care to every single person, each person individually, to really achieve equity. All of this affects health outcomes in cancer care. Death, so mortality, morbidity, life expectancy, health status, functional limitations, and healthcare expenditures. And I'll focus in again on socioeconomic status and its components and how important this is to really address. About 21% of African Americans and 18% of Hispanics were living below the federal poverty line in 2018. compared to 8% of the white population who were not of Hispanic ancestry. We know that the socioeconomic status of individuals and neighborhoods can affect clinical, environmental, psychological, behavioral, and cultural factors that influence our health. And that includes access to healthy foods, spaces for physical activity, the internet and transportation, as well as exposure to crime, violence, and social disorder. Establishing how much each factor contributes to racial and ethnic cancer health disparities is vital, and we are to engage new sectors. Everyone should be engaged in this conversation. So education, housing, agriculture, transportation, environmental, and all of these worlds coming together will truly help us to understand the gravity of cancer health equity and to make actionable plans to eliminate. The complexity of the issues of access to quality cancer care is not only influenced by health insurance status, but is also influenced by factors such as whether an individual will accept or decline the use of cancer care services or treatment. Are these services easy or difficult to use? If individuals can get to facilities where care is being offered, then great, but many times that's not the case. Language barriers, there's fear of discrimination, and then there's the issue of health literacy as well. If we look at the physical environment, that contributes significantly to racial and cancer health disparities as well. There was one study showing that African American women were significantly more likely to live in a disadvantaged neighborhood than white women. And this was a very important factor contributing to disparities in triple negative breast cancer, stage of diagnosis, and survival. And we know that this is one of the most aggressive cancers. In other studies, living in a disadvantaged neighborhood has been shown to contribute to disparities between African Americans and whites in liver cancer and prostate cancer incidence and survival. Let's look at the cancer control continuum. And at the very bottom, those pink arrows show some of the cross-cutting issues that essentially span the prevention all the way to survivorship along the cancer care continuum. So disparities in each of these different areas, or complexity related to each of these different areas, communication, surveillance, the social determinants I've discussed, the genetic testing, decision-making, dissemination of evidence-based interventions, quality of cancer care provided, and then making sure that the data is truly reflective of our diverse community. So the epidemiology and the measurement pieces are all important. This essentially shows the need for an intersectional approach. So we know that research in health disparities shifted from a single dimension models to very complex frameworks. And this really describes that. So you've got your behavioral, your biological, the physical or built environment, as I mentioned, sociocultural environment, the healthcare system. And levels of influence, as I mentioned, happen from the individual level, interpersonal level, community level, and societal level. And these frameworks essentially provide a thought structure that helps us to integrate biology and social analyses to bring out new hypotheses so that we can make, not just move the needle, but eliminate these disparities. Now, progress in understanding mechanisms and subsequent reduction in an elimination of these disparities has been relatively slow. And the slow rate of progress has partly been due to the lack of adequate data support, lack of biospecimen availability in diverse populations. The pandemic, as we mentioned in the very beginning, has numerous consequences secondary to the disease itself. So during the pandemic, with everything shut down, there was reduced access to care for many other illnesses. I know that in my own practice, not only did I see patients not wanting to come in who were having chest pains, they had heart attacks at home because they were so afraid to go into the healthcare system. Many patients who had cancer diagnoses, knowing that a lot of the healthcare resources were diverted to help the growing number of individuals who became ill with COVID-19, that suspended a lot of urgent healthcare. So there were so many delays in cancer screening and diagnosis and treatment, and reduced healthcare access that in the short term, it's going to reduce the diagnosis of cancer. But in the long term, we're going to see increases in late stage diagnosis and preventable cancer deaths. Some individuals may continue to delay preventive care and symptom follow-up because of the fear of exposure or the loss of employment or employer-based healthcare. These ramifications are particularly going to affect historically disadvantaged communities that already have challenges accessing quality medical care and who are already facing a disproportionate burden of COVID-19 illness, hospitalization, and death. I served as a principal investigator on a study where we looked at racial and ethnic disparities in COVID-19 outcomes. And we looked at this nationally, and we were published in the International Journal of Environmental Research and Public Health. And the disparities that we saw across the country as compared to the population representation of each racial and ethnic minority was staggering. And that's overlaid now with cancer care disparities. We have quite a lot of work to do. The situation that I'm describing now is a snapshot in time, but because of the effects of the pandemic, that's going to become significantly worse, and it will take all hands on deck, all of us together, working to ensure that we eliminate these disparities and improve the health of our country. Here is another snapshot showing disparities in cancer treatment. Now, yes, we're continually developing new cancer treatments, but there are several segments of the US population who really don't receive these standard recommended cancer treatments. For example, patients with intrahepatic cholangiocarcinoma who are Black are 50% less likely to have surgery compared to patients who are white. Women with carcinoma in situ in the breast who live in rural areas are 29% less likely to receive radiotherapy after breast-conserving surgery compared to women who live in urban areas. And among patients with locally advanced soft tissue sarcoma who were treated with limb-sparing surgery, those without health insurance were 27% less likely to receive neoadjuvant and adjuvant radiotherapy, so basically therapy before and after the main treatment, compared with those who had commercial insurance. And in patients with metastatic bladder cancer who are of low socioeconomic status were 50% less likely to receive chemotherapy compared with those of high socioeconomic status. Let's talk a little bit about some of the lack of genetic diversity. I know that the GWAS studies I've described, but only 2% were African American lineage, 1% were Hispanic, 10% were Asian, and less than 1% of the GWAS or the genome-wide studies with detected genetic alterations. We cannot use that data to extrapolate to our racial and ethnic minorities. Now let's talk a little bit more about the COVID-19 pandemic and the future of cancer outcomes. During the pandemic, as I mentioned, we had reduced access to care. There was a fear of infection. We didn't want to go into any healthcare facilities. Many patients' resources were reallocated elsewhere. And if you had treatments or procedures scheduled, all of those were canceled. So that reallocation definitely played a very big role. There was unemployment leading to financial insecurity and insurance loss, and there was shutdown and social distancing that happened that compounded some of the psychological and stress-related issues that I mentioned earlier in the presentation. On the prevention and early detection end of things, I mentioned delayed routine care. So preventive visits, screening was very much delayed or canceled. Abnormal test follow-up was put off, and any symptom follow-up was also put off. On the diagnosis side, there were fewer treatment options, more intensive treatment, and that essentially caused lower probability of survival because now you have a late stage diagnosis. In the treatment arena, there was postponed surgery, postponed radiation and chemotherapy, less intense chemotherapy, and non-standard care was given. We're looking at data snapshot from electronic medical records from about 190 hospitals. If you look at in the very beginning of when we diagnosed our first COVID-19 case in the US, that was about January 20th of 2020. It showed from looking at those electronic records that the number of screening tests for the early detection of cervical, breast, and colon cancer conducted in the United States plummeted by 85%. Just think about that. We'll think about the repercussions of that as well. And then a recent study of patients with cancer found about a 79% of those who were actively undergoing treatment had to delay some aspect of their care as a result of COVID-19, including 17% who reported delays to their cancer treatment. It will take us many years to determine the consequences of all of these delays, but researchers at the National Cancer Institute have estimated that there will be at least 10,000 additional deaths from breast cancer and colorectal cancer over the next decade here in the US. And the result of the negative, and all as a result of the negative impacts of this COVID-19 pandemic. We know about the unemployment skyrocketing, the loss of income, and how that has certainly created a ripple effect. We know that that's the potential again to reduce cancer screening, not only for the detection among people with who are racial and ethnic minorities, but that also increases the likelihood of any cancer being identified at an advanced stage when it is less likely to be treated successfully. This also has a potential, of course, to intensify disparities in treatment and other aspects of cancer care. Another factor that's likely to compound existing cancer health disparities is that public hospitals that provide safety net health care and general medical care, including cancer care, and they provide this to a disproportionate volume of people in racial and ethnic minority groups. Those hospitals have been hardest hit by COVID-19. So the economic impact of the pandemic on these already financially constrained healthcare systems, it's going to essentially compromise cancer care further. Then people of racial and ethnic minority groups are also less likely to have capability for advanced communication technology. We know that most medical offices switch to telemedicine, and many of our community members who don't have access to this technology with limited access to healthcare and follow-up. So in the short term, while that worked for many people, are those who are already affected and affected disproportionately, the intense effect was magnified. So in this post-COVID-19 era, and I hope we can call it post-COVID-19 era very soon, there is an urgent need to ensure that we have comprehensive healthcare and we have economic interventions in place for equitable recovery of cancer care. Health insurance coverage opportunities should be expanded, Medicaid programs, for example, to help financially constrained individuals. Public hospitals need further support. Public health and educational messaging needs to be tailored to racial and ethnic minority groups, and that must be developed and implemented to increase COVID-19 testing among those segments of the population. We also don't know the effect of the virus itself on cancer itself, and that requires study, but it requires study in a very diverse population. Clinical trials need to absolutely have a better representation of racial and ethnic minorities, and basic research with an understanding of the viral biology needs to have that understanding in the diverse host environment. So as the cancer research community recovers from COVID-19 pandemic, it's vital that cancer health disparities, including community outreach, education, engagement, that all of that is protected from budget constraints that arise from these adverse financial impacts of the pandemic. So if we have funders here, if we have others who want to be engaged in this work, it's important that we have all hands on deck. The National Cancer Institute gave us some examples of cancer disparities in different groups. Breast cancer, for example, in our African American women are nearly twice as likely as white women to be diagnosed with the most aggressive breast cancer, triple negative breast cancer. And they're much more likely than white women to die from breast cancer. Looking at kidney cancer, the highest rates of kidney cancer cases and deaths in the US occur among American Indians and Alaska Natives. Rates of liver cancer are higher among American Indians and Alaska Natives and Asian and Pacific Islanders than any other racial or ethnic group. Prostate cancer, African American men are more than twice as likely as white men to die from prostate cancer. I had a patient of ours, actually, he was also our landscape of our medical office. He came, very much, he was always on time, very hard worker, always did the most detailed job. And one day we heard a shrieking loud scream as we were in the office seeing patients. We ran outside and we saw him flailing his arm, his left arm. He picked up one of his pieces of equipment to cut the hedges. And just by picking up that cutter, his arm broke. We took him inside, started to take care of him, realized that he had metastatic prostate cancer that had spread to the bone. And that was a pathologic fracture. So just a small movement like that broke his arm. He died just a couple months later. He had a late stage diagnosis, and he was an African American man. He had 5 children. And I remember that we brought the community together as best as we could to help whenever we could to take care of some of the children and some of their needs. Cervical cancer. Women in rural areas, we know, are twice as likely to die from cervical cancer as women in more urban areas. And multiple myeloma, let's look at that. African Americans are twice as likely as whites to be diagnosed with and die from multiple myeloma. I talked about breast cancer being more triple negative breast cancer in African American and Black women. Why is that? We know that there is some evidence that shows that higher parity, or basically higher pregnancies, in the absence of breastfeeding is associated with an increased risk of hormone receptor negative or triple negative breast cancer in the US. Breastfeeding prevalence is markedly lower in African American and Black women than any other population. Looking at type 2 diabetes and obesity, which are more common in African Americans and Blacks and the Hispanic and the Latino community, that also can increase the risk and progression of breast cancer, particularly hormone receptor negative breast cancer. There are some other risk factors that we need to look at. Insulin resistance, a risk factor for prediabetes and type 2 diabetes, which promotes weight gain. That weight gain in turn causes inflammation in your tissues, right? The inflammatory cytokines, or those inflammatory chemicals essentially, and associated immune cells that are involved in this process, they essentially activate signaling pathways that promote more aggressive triple negative breast cancer phenotypes. In addition, African Americans, Blacks, Hispanics, and Latinas are likely to live in low-income areas with high exposures to environmental pollution, and emerging epidemiology evidence supports a possible role for hazardous air pollutants like traffic emissions and radon in breast cancer, right? Research has to focus on the interplay between race, ethnicity, poverty, diet, obesity, and aggressive tumor biology. And that will truly exemplify the richness and the complexity that is associated with the outcomes that we're seeing. So you're really looking at an eco-social multi-level theoretical framework. So we have to go beyond genetics and focus on the entire comprehensive picture. Just quick comment on the liver cancer deaths. We know that the hepatocellular carcinoma or liver cancer remains the fastest rising cause of cancer-related deaths between 1999 and the incidence rate also rose dramatically during this period, secondary only to thyroid cancer. The American Indian and Alaskan Native populations had the highest rates. If we look at a snapshot of cancer death rates by race and ethnicity, our Black community continues to be more affected than every other racial and ethnic group. If you look at cancer statistics for African Americans from 2019, prostate cancer and breast cancer in men and women respectively are the highest number of new cases. And as far as deaths go, lung and bronchus cancer in males and female African Americans remain the highest. Let's take a little bit of a data dive into prostate cancer a little bit more. This graph shows you the age-adjusted rate of new cases of men by race and ethnicity of prostate cancer. You, of course, see our African American males have the highest rates, and prostate cancer disparities actually constitute the largest of all cancer disparities. African American and Black men essentially suffer disproportionately from prostate cancer. They're more likely to be diagnosed in younger age, present with more advanced and aggressive disease, and have at least a 2 to 3 times higher mortality compared to non-Hispanic white men. And if you look at the prostate cancer new cases, there were only about 250 prostate tumors from African Americans and Blacks who have been studied. And to my knowledge, from reading the data, no tumors from Hispanic and the Latino community are included in any existing characterization study. We have to do better. Prostate cancer, the death rate, as I mentioned right here, is significantly higher. You notice a separation between the blue line and the other color lines here. That is showing you again in the Black community, that large disparity. And furthermore, we note that men from racial and ethnic minority populations and those on a lower income, they reported worse bowel and urinary function and more sexual dysfunction than non-Hispanic white men after a prostate surgery or after radiation. That reflects poor quality treatment and follow-up care and some disadvantages that happen prior to treatment itself. So we really have to look at that a little further and do a better job risk stratifying before we have our patients all go through the same process. You look at lung and bronchus cancer. Lung cancer is actually the leading cause of cancer mortality in the United States. This is male lung and cancer and bronchus cancer. There are different behaviors that certainly affect it. Of course, smoking, mentholated cigarettes, for example, being less successful with some of the cessation therapies. And there are some additional genetic and epigenetic mechanisms as well that contribute to this. If we look at the adjusted death rate in men, the African Americans and Blacks are diagnosed at a younger age and with more advanced disease than non-Hispanic whites. Now, although Hispanics and Latinos, especially those foreign-born, show lower mortality than non-Hispanic whites, they're still diagnosed with more advanced stage diseases. And both groups are less likely to receive standard of care or to undergo guideline-recommended PET and CT imaging at diagnosis of like non-small cell lung cancer at all stages. So those disparities certainly are ever prevalent and have not changed. In fact, they've worsened. Male colorectal cancer, again, African American men are disproportionately affected. This is the death rate, again, very much so. I would say that African Americans and Blacks, for males and females, have the highest incidence rate of colorectal cancer. The underlying factors driving disparities here in colorectal cancer mortality have not been conclusively determined. However, lower screening rates, more advanced stage of diagnosis, differences in treatment patterns, and unique tumor biology are all believed to contribute. In my early days of practice, I had a patient, an African-American female. She came in, she was in her 30s. She wasn't feeling so great, and she was dismissed by a whole bunch of physicians who saw her previously. They thought that she was emotional. They thought that she was histrionic, and they dismissed her. So she came in to see me, and we were talking for a little bit, and she explained to me that she was having a couple of GI symptoms, and throughout the course of the exam, she definitely did not meet the criteria for a colonoscopy. But during the exam, based on just the physical exam and the conversation that I had with her, I decided to have her go for a colonoscopy. She ended up having a right-sided early stage colon cancer. And that, again, is an aggressive location for a cancer. We really have to be in tune with our patients. And while, yes, we have guidelines to provide clinical care, listening to the needs of our patients and then following not just the science, but our medical intuition is also necessary. And that shows here as well, too. Female colorectal cancer, again, the highest numbers are in the Black community. And there's so many different factors associated with this. We really do have to take a very granular approach. But it's not just about gene-environment interactions as well. We're looking at psychosocial, behavioral, and other exogenous agents that are going to essentially affect this. Female lung and bronchus cancer, the death rate in women. Lung cancer among never smokers is becoming an increasing problem in populations with low rates of tobacco use, with over 50% of lung cancer cases actually being diagnosed in East Asian women, right? So this requires a significant data dive looking at those numbers. Female breast cancer. Our Black community is disproportionately mentioned. I mentioned already about African American and Black women essentially are twice as likely as non-Hispanic white women to have triple negative breast cancer, which is one of the most aggressive types of breast cancer. If we look at this particular chart, I use little arrows to show you the increased mortality from specific cancers. This is between 2012 and 2016. You will see that for the non-Hispanic Black community in all sites, we have the highest numbers. Colorectal cancer, non-Hispanic Black community, male and female have the highest numbers. American Indian and Alaskan Natives have higher gallbladder cancer, kidney, renal, and pelvis, liver, and intrahepatic bile duct. And then you will see the descriptions in different areas. This shows you that we don't have the answers. We don't know the factors that are contributing on every single level, and it requires a comprehensive approach. If you look at our American Indian and Alaska Native population, cancers with the highest incidence rates here in this community are all outlined here on the left of the slide. So stomach, lung, liver, kidney, and colorectal. And this is a data snapshot between 1999 and 2015, showing significant increases in kidney cancer, liver cancer, and breast cancer. We absolutely have to make sure that we are not only culturally appropriate, but we are community-based interventions, that we have community champions, we have members of the community at the table, and as a part of our clinical care team in order for us to move the needle. Access to services, preventive services, And talking about exposure risk in the built environment is essential, and modifiable risk factors, as I've mentioned. So let's talk about that intersectional approach. An intersectional approach, really, this term intersectionality, Kimberly Crenshaw is the one who coined this term. She is a lawyer and civil rights advocate. Essentially, intersectional thinking presents a range of concepts right here, and it's really simplified by this visual diagram, but it's essential complex interactions that will essentially confound an individual's own set of privilege and oppression that will be created. So you have the overarching macro factors. We have classism, colonialism, ableism, which is, basically being biased to able-bodied people, racism, patriarchy, cisnormality, and homophobia. And then on the micro level, you've got factors related directly to the individual themselves. There is overlap of these areas to create that intersectionality. And it basically, as I mentioned, creates a range of forms of privilege and oppression. And this has a direct effect on health disparities in general. There are systemic barriers that will happen to opportunities and multiple forms of prejudice that happen from intersections in these domains. And a recognition that there are these unique forms of oppressions and privilege that occur, that is only the first step in adopting an intersectional approach. We know that forms of systemic discrimination intersect with each other and present unique challenges for affected individuals and communities. It's important for us to respect the voice of those most affected by issues by centering in on their voices. Being inclusive and incorporating different perspectives when we're talking about our issues is critical. And acknowledging that individuals with intersectional identities may face unique challenges in how their families are perceived and in building and sustaining their communities. So let's translate that to public health. In the public health framework, intersectionality will provide public health with a unifying, interpretive, and analytical framework to really reframe how we conceptualize, investigate, analyze, and address disparities and social inequality in health. One of intersectionality's greatest strengths is really its broad embrace of those multiple intersecting identities with multiple interlocking privilege and oppression. So really no social category or form of social inequality is more salient than another from the intersectionality perspective. And social categories are not additive and they can't be ranked. So intersectionality is substantially useful, but it's really not used as much as it should be. This really allows us to have a different lens, through which we can see the variety of factors and how that they integrate with each other to create the disparities that we're seeing today. So as far as our suggested actions to advance research and reduce or eliminate cancer health disparities, we must have further development and sustaining large, diverse cohorts to collect multidimensional, multi-level data, including all the social determinants of health that we've described. We can harness the power of big data through EMR interrogation to really understand clinical care journeys. Germline and tumor genetic databases in clinical trials need diversification. And we also need to develop diverse cell lines and patient-derived xenograft models. Implementing system changes in healthcare will help us to guarantee equity and access to high-quality screening and access to treatment. Patient navigation programs and the use of community health workers, for example, are essential, and making sure our patients are at the table. Ensuring a community-based participatory research model will allow us to create culturally tailored programs for community awareness that really highlights the voice of our community. And disease prevention and education is an important part of that, and ways that we can help modify some of the risk behaviors. And implementing legislation that supports behavioral interventions. For example, limiting the sale of certain products that cause increases in cancer, like tobacco products. So it's essential for us to come together. In our program for the Caribbean diaspora, we created culturally appropriate materials. Our goal is to reduce obesity, but in a way that was highlighted by our Caribbean community itself. So that was just one example of some of the ways that is showing you the big data approach. We're actually engaged right now in an NIH. We're putting together an NIH grant with many different partners at the table. We are harnessing the power of big data to truly get a bigger picture idea of what's happening in COVID-19. Big data resources are very powerful because of the volume, size, the breadth of data that's captured. compared with just clinical trial data or data from academic centers and consortia. The information may better represent vulnerable patient populations, such as minorities and elderly patients, and all of the patient populations I described today. There are also tools and analytical methods and modeling that can be done to develop risk indices and to truly help us to make some actionable changes. These are areas for prevention. All of these areas right here, we can reduce cancer risk by each area. By tobacco smoking, almost 20% cancer diagnosis can be reduced. By smoking tobacco causes that. Excess body weight, for example, if we were to, that's 7.8% cancer diagnoses are related to obesity and being overweight. 5%, or a little bit over 5% of alcohol consumption is related to cancer diagnosis. UV light, diet, cancer-causing pathogens, and physical inactivity. You see that all of these are modifiable risk factor areas that we can definitely broach with our patients, but not only broach with our patients, make sure that we are understanding the unique challenges that they're facing in preventing some of these modifiable risk factors from causing an issue. This slide shows you cancers that are associated with obesity, those associated with physical activity, and those associated with both. So we can absolutely make an impact on cancer health if we were to reduce obesity significantly. Working together, we know we can eliminate cancer health disparities. It takes all of us here at the table to be able to do that. So our patients, our survivors, caregivers, family members and friends, all of the academic communities and the government researchers from diverse specialties need to come together. Our individual citizens and advocates, our regulators, our funders, payers, philanthropic organizations, cancer research organizations, Gilda's Club here today, policymakers, biotechnology, pharmaceutical, healthcare providers. And we absolutely need to have more diversity in the workforce that's reflective of the diverse population that we're seeing. And that diversity in training is essential. So implicit bias training and ensuring that we look at our own biases. So this is showing you some of the technology advances that we've had, but none of this has really just impacted all of our racial and ethnic minorities that I've outlined today for all the reasons I've described. An intersectional approach to cancer care really allows us to take our awareness to a new level. To look at our own implicit biases, we all have implicit biases. To use disaggregated, transparent, and individualized data. To understand that as intersecting oppressions and struggles, issues and cross issues are affecting each individual patient. And with empathy, we will essentially have culturally tailored communication and eliminate these health disparities towards achieving health equity. Our approach needs to be inclusive and collaborative. We need to punctuate that with allyship, advocacy, and respecting the voice of our community. And I'm a very big supporter of community-based participatory research. If you would like to take an implicit bias test, you're welcome to do that. We highlighted this in our Department of Internal Medicine session on disparities related to breast cancer. So I'm happy to share this with Belinda and the entire team so that we can all look at our own biases. And then finally, I'm going to end on a quote by Dr. Cardinal Smith from Mount Sinai. He was asked, he said, studies show that the lack of exposure to an ethnically diverse oncology workforce is a barrier to good health. Would having a more diverse oncology workforce achieve greater health equity and potentially improve outcomes in minority patients with cancer? He says, yes, I definitely think it would. When there is racial or ethnic concordance between patients and physicians, patients report greater trust and satisfaction in the oncologist and tend to be more adherent in their treatment regimen. Although Blacks and African Americans make up 13% of the US population and Hispanic or Latino Americans make up 18% of the population, just 2% of the oncology workforce self-identifies as Black or African American and 3% as Hispanic and Latino. Thus, having a more diverse oncology workforce would make a huge difference in the care of minority patients. I want to thank you all so much for the time today. This, again, is just the very beginning. It is us converting our conversation into action. I'm looking forward to us having powerful, collaborative work together. Thank you so very much.